up for you today. So I'm excited for you all to be here. Before we get started, I just want to do a few housekeeping things. Please be sure that you sign in so that you can claim your CE at the end of the activity. Please, for Zoom etiquette, if you have any questions, please enter them in the chat. And at the very end of the presentation, we will then facilitate your questions. We have our next presentation on PCORI updates scheduled for Tuesday, October 8th. So we look forward to seeing you again. And please consider being a member of SMCI. And if you have any questions on how to join, please reach out to myself or Selena Meza or even Lisa Freeman. I see Samantha Kling on here as well. So, and we have a website, so more to come on that. We can put that in the chat for you as well on how to become a member. So without further ado, I'm going to go ahead and present our speaker. So I have here Christopher Tofanelli. He's been a clinical nurse specialist here at Stanford Health Care in California since 2022. And he covers right now our colorectal, urology, hepatobiliary, surgical oncology service lines. His expertise includes cardiac surgery, emergency medicine, pain management, and trauma. He has received his master's degree in CNS and nursing from California State University, Dominguez Hills in 2022 with a focus on improving quality outcomes for surgical patients. Chris has held many positions in his 10+ years of nursing experience and includes clinical practice, assistant patient care manager, preceptor, and project manager. He also had a previous career as a high school math teacher for 10 years before becoming a nurse. So thank you, Chris, and we look forward to your presentation.
Okay, can everybody see my screen okay? You can hear me okay?
Yes.
Excellent. Well, first of all, thanks for coming to my presentation. This is about the second or third time I've given this presentation, and I'm pretty excited about the work that we've done here. Like Sabrina was saying, my name's Chris. I'm the clinical nurse specialist here at Stanford, and I'm here to talk about medical cannabis, breaking the glass ceiling for inpatient care and use, pun intended there. I don't have any disclosures or conflicts of interest. I don't work for any medical cannabis companies or big pharmaceutical companies. So everything that you see here is going to be free of bias. And here's my agenda. If you asked me 12 years ago when I first started my nursing career, if I thought I was going to be discussing cannabis use in hospitals, I probably would have laughed at you. But over time and exposure to a lot of patients and a lot of various settings from oncology, cardiac, trauma, GI, I do believe that there is a place for medical cannabis in inpatient medicine today. And so during this talk, I'm going to be presenting some patient stories, what their outcomes were, and how some of them even shaped the medical cannabis landscape. And I'm going to, like I said, I have a pretty good agenda here, but I really want to make sure that everybody's on the same page with medical cannabis. So I'm going to start off with some historical concepts, basic definitions, then we'll move into the safety profile of cannabis, discuss some of the barriers that we encountered in this work. This is pretty novel work. It hasn't really been done anywhere else in the country. And then how we made the process work. And then most importantly, what's the patient impact? So this is where it all really began. This is one of the first medical cannabis patients that I ever took care of. This patient was diagnosed with bladder cancer, which had metastasized to his abdomen, his pancreas, and his spine. And I do have permission to share his story. He had a pretty poor prognosis, just 1 to 2 months to live. Hospice set him up with a medication regimen, which included morphine, Ativan, and lidocaine patches for his back pain, and then as well as Oxy and Seroquel. And this is a common regimen that we see with patients in and out of the hospital, but it just didn't really work for him. His sleep-wake cycles were all affected. His meditation was off. His emotional well-being was affected. And we knew he had just days to live, so the family was really desperate to try anything. And his close to dying wish was, I just want to be with my family. I want to be able to hold my grandkids one more time. And so the big question here is, would medical cannabis help? And so we will revisit this story at the end of the presentation here. So again, I said I wanted to make sure everybody was on the same page here. What is medical cannabis in terms of our talks today? Many people are pretty familiar with it, especially since it's pretty much legal here in California. But I want to make sure that for the definition's sake that we're all on the same page. So cannabis contains more than 80 biologically active chemical compounds. The most common ones that you hear about are tetrahydrocannabinol, which is THC. That's off of the flowering parts of the plant, and then cannabidiol, which is CBD. And the main difference between those two is that THC is mainly used for pain relief, increased mood and anxiety. So when people talk about marijuana or cannabis, a lot of times they're talking about THC. CBD is the second most common biologically active agent, and it's not psychoactive. It's mainly used for patients for anxiety, insomnia, pain, and even some studies show addiction to other medicines. And most of the patients that we see here are using a combination between the two. And there's many routes of administration. And for the purposes of this talk, we're going to be focusing on the non-inhaled types. And I'll talk about and discuss what some of those are. So a little bit about the historical context of cannabis. It's been controversial for almost 100 years. If you look at how cannabis became illegal in the United States, there's a lot of different theories as to why that is. And that's a whole nother discussion. What is important to know is that from this timeline, things are fast moving towards legalization. So really, despite what your feelings are about cannabis, whether you use it, whether you don't use it, whether you support medical use or not, we're really approaching a state in which most Americans, it's above 70%, I just Googled it today, support legalization. And many states have some sort of legalization that allows for medical and or recreational use. And so what we're starting to see is patients coming into the hospital requesting to use it. And they're using this as in conjunction or sometimes as a substitute for other commonly used inpatient medications. So as a medical professional, whether you're a nurse or a provider or a case management social worker, you're likely going to encounter a patient who wants to use it. And while many hospitals have firm standards on not allowing that usage, that could really change soon. In fact, the U.S. Department of Health and Human Services and the FDA have both given their approval to reschedule cannabis to a lower level, and that could happen as early as the end of this year. So if that happens, things are going to be changing drastically. Okay, so to give you another snapshot about how things are moving quickly, this is a map of the US around 1995, so less than 30 years ago. No state had legalized medical or recreational cannabis. California was the first one. They were the trial state, so to speak, and they did so in 1996. And then what you can see from this video is that legalization in one form or another has really just exponentially increased. The green states that you see popping up here on the map are states that have legalized it for medical use, while there are some gold states that are popping up. Colorado and Washington were the first. And these are states that have legalized it for not only medical use, but also recreational use. And then you're also going to start to see these little red Ds pop up on the map. And these are states that have decriminalized cannabis to some extent. And so I show you this map because in less than 30 years, the legalization, the socialization, and the acceptance of cannabis has really almost reversed. In fact, there's only 2 states in the US that still have cannabis illegal, both federal, at the federal level for recreation and medicinal, and that's Idaho and Nebraska. And I believe there's actually legislation on those 2 state ballots to get that changed. So again, despite what your personal feelings are for your own nursing practice and for hospital quality, it's wise to know what to expect from it. So that's a little bit about the historical context of it. I also want to move into the therapeutic effects of cannabis. Here are some tables that are taken from the National Institute of Health. And I'm not going to go through each one, but I just want to highlight a few. The slide's broken down by evidence. So it's either substantial over off to the left, all the way to insufficient evidence over off to the right. And there's substantial evidence that there's relief from pain, nausea, and sleep, particularly for those patients who are oncology patients. We see a lot of usage with our oncology populations. There's also some limited evidence that it can improve anxiety, PTSD, and improve appetite. But there's still insufficient evidence regarding mental health outcomes, which is actually a really big topic right now. But cannabis, like any other drug, is not benign. It can cause accidents. It can trigger respiratory symptoms. It can trigger heart attacks, particularly with patients who smoke it. And it can cause acute cognitive impairments. There's also been quite a lot of research, although it's really conflicting, that persons under the age of 25 can have adverse mental outcomes from cannabis use. But again, that's really inconclusive. And so some people consider it to be a wonder drug, but it still can cause harm. And that's the takeaway here. Nothing here is really benign. So is it truly safe? It depends under the context in which you're asking that. If you look at the safety profile compared to other drugs, it's got a 1 in 20,000 therapeutic ratio, meaning you'd have to take 20,000 times the amount of a therapeutic dose to be fatal. That's about 1,500 pounds of cannabis in 15 minutes. Not even Snoop Dogg or Willie Nelson can do that. It's pretty much almost impossible to overdose on it. Second, it's shown to be less addictive than nicotine, caffeine, sugar, alcohol, opioids, and it has one of the best withdrawal symptoms compared to everything else we get in the hospital. It can cause fluctuations in blood pressure, heart rate, and mental health changes, as I mentioned before. It can also increase motor vehicle accidents, as well as there is some inconclusive evidence about causing infertility as well. But overall, from a safety profile compared to a lot of the drugs that we give in the hospital, it's quite safe. So how did we get here from a legal standpoint? The person that you see pictured here, his name is Ryan Bartel. He was a California resident, and he was just 41 years old when he was diagnosed with pancreatic cancer, stage 4. He was getting heavy doses of morphine, fentanyl, and wasn't getting any relief. And after about some weeks of doing that, he requested to use cannabis. Unfortunately, at the time, this was in 2018, there were no laws about cannabis. It was pretty much outlawed anywhere. And so what his parents did was they relocated him to a Washington hospital to use medical cannabis. And according to the staff who took care of him and his father, his condition and mentation improved drastically, and it granted him a decent quality of life in his final weeks to live. The silver lining of this whole story is that his father lobbied for a Senate bill, that's Senate Bill 311, which allows a terminally ill patient to use cannabis in the hospital. So this whole story was really the impetus to drive our policy change. We were mandated at a Senate level to figure out a way how to allow it in the hospital. Here's Stanford Health Care's timeline. And so to really understand the policy and interventions created, it's important to understand the legal barriers. The medical cannabis policy actually goes back about 10 years. We did have a previous policy on that, but as you could see with all the changes to the legality of it, things have changed a lot. We needed to update our policy. We started working on that in 2019, but all that was tabled due to a little thing you might remember called COVID. And when the Senate bill passed and COVID started settling down, we started working on it again. It was not an easy policy. It was actually one of the first policies I ever worked on. So it kind of jaded my perspective a little bit, because I was like, man, these policies take forever. It took over a year to develop. We had to do a lot of care coordination. We had to partner with palliative care, Department of Public Health, pharmacy, risk management, ethics, EPIC, you name it. and they were involved. And so a lot of moving parts to this. More about the legal barriers to medical cannabis. And this is where it gets really dicey, and how the protocol is what it is today. The main things that we had to contend with is that cannabis cannot be administered by hospital staff. It can't be stored by the hospital. There has to be a physician recommendation for cannabis, and the way it's written, it actually has to be the attending. Patient has to be deemed terminally ill, and pharmacy won't even sign off on it. And so you might be wondering, like, how are we going to do this? You know, it can't be stored. It's a Schedule I drug. Pharmacy wants nothing to do with it. Security wants nothing to do with it. Oh, and what's not on this list is that the patient can take as much as they want, and it's not even required to document how much they take. So you can imagine how difficult it was to create a policy that really encapsulated all of this, but still made it safe. I talked a little bit about route to cannabis. So everything that you see boxed in green is really what we see in the hospital today. Anything off in the red on the right is not allowed. So what we typically see patients requesting are edibles. These are come in the shape of gummies, or they might be in like an oil tincture. We've seen some patients have topicals like a salve, and even some patients have suppositories as well. Anything over to the right, which is what a lot of people think of when they think of cannabis, flower, or a vape pen, or joints, stuff like that is not allowed in the hospital, and that a lot of that's due to our anti-smoking laws that we have currently. So I just wanted to make sure that you had an idea of what is currently allowed in the hospital. So to really understand the policy and interventions created, we have to talk a little bit about that whole Schedule I status. So Schedule I means that it has no, quote, currently accepted medical use and a high potential for abuse. And that's the same designation that we give to other drugs such as LSD or lysergic acid, heroin, and MDMA or ecstasy. And that's a very debatable topic. A lot of people don't feel like it should be Schedule I. Our common opioids that we use in the hospital, such as oxy, morphine, and fentanyl, are all Schedule II. And in talking about safety, opioids are responsible for about 80,000 deaths per year, and those are all Schedule II. Alcohol, what's not even on this list, is responsible for over 140,000 deaths per year. And as a comparison, 99% of cannabis-related deaths are accidental in nature. There's actually been no documented overdose from cannabis to date. And as I mentioned before, the HHS and FDA have both recommended rescheduling cannabis, so this could change in the future. But it's really hard to show the therapeutic benefit of cannabis, because when a drug is Schedule I, it makes it nearly impossible to do research on that. So anytime you want to show a benefit of it, it has to go through miles and miles of approval, and it's pretty much very costly to do and very difficult to do. And so those are some of the things that we had to contend with. So what I wanted to show you was how we created this algorithm to allow patients in the hospital. This is a pathway for physicians to use. If you've had a patient request to use medical cannabis, you might see this algorithm in our policy. And this pretty much tells you when and how a patient can use it. So it starts with a patient when they bring in cannabis, assuming it's in a non-smokable form. Here at the top, we ask if it's an edible form or non-smokable, like a topical, we can allow that. If it's not in one of those forms, it's prohibited, and we request that it be taken away or that security dispose of it. The next question it goes down to is, does the attending physician approve cannabis integration into the plan of care? If they do, this process is pretty straightforward. It's really easy. There's a whole risks, benefits, and alternatives discussion. There's a consent form that's signed. We have a whole storage box that we bring out to the bedside, which I'll show you pictures of. And then we have a whole MAR order, which I'll get to. Now, I want to circle back here. What happens if the patient or the attending does not approve of the plan of care? And then it gets into that whole question, is the patient terminally ill? And we use the definition that's used in the Senate law, which is a patient with a medical condition resulting in prognosis of life of 1 year or less if the disease were to follow its natural course, which, as you can imagine, could be a lot of patients in the hospital. If that question is yes, or the answer to that is yes, then we get down to a decision: do they have a medical marijuana card, or do they have some sort of written documentation? If they have one of those, then by law, we have to allow that. Now, we've had probably in about over a year, somewhere between 50 to 100 patients at Stanford at this facility request to use it. And I think only twice did we actually have to go through and tell the physician that they had to use it because of Senate Bill 311. Most of the providers that we work with are pretty willing to allow the patient to use it. So that's the plus part of it. I wanted to show you one of the acknowledgement forms that we created. And this was one of the main speed bumps that we came into, was that a patient doesn't always have a medical marijuana card. Maybe 10 years ago they might have, but nowadays it's pretty easy to acquire cannabis in the state of California. And so when patients were coming in requesting to use it, they didn't have anything to show for it. So what we did was we created this document. It's almost like a consent form. It talks about the safeguards, the limitations, the responsibilities. This document signed by the patient and then the attending, and then it's sent into the patient chart. We tried to make this as easy as possible. We created links to this in our algorithm. And so once this is signed, can actually be used in the future by patients if they want to use it again in the future, like in case they're readmitted for some reason. I talked about the aspects of storage. Again, just as a reminder, pharmacy and security don't want to store this. They don't want to have, they're actually not really allowed to store it. So what we had to do is we had to procure these medical lock boxes. And the way these work, it's like a double lock box with 2 keys. The patient has a key and the staff has a key. So assuming that the attending physician signed off, one of these is procured from our patient equipment supply. We give the key to a patient, and then the unit holds onto a key. And then anytime the patient wants to self-administer cannabis, what they do is they just call the nurse. They open up the lockbox. It's almost like a 2-person nuclear authorization. And then it allows the patient and the staff to know how much they're dosing, as well as it curbs any sort of allegations of theft, since it requires the patient and staff to open it. And then another part that we found that was lacking when we were developing the policy with this was that the known interactions and side effects with cannabis, especially in conjunction with a lot of the other medications that we take. And so you can imagine for those terminally ill patients, how many medications we're actually giving them. So this tip sheet was created in conjunction with our pharmacy colleagues. They did a really good job of doing a deep dive in the available research that we had. And then what we also did was we stratified it by THC and CBD, since some patients are taking one or the other, or both. And this has been really helpful to ordering providers because they can see what other medications they're on. For example, cannabis can increase the risk of INR in patients taking warfarin. And so a lot of times when patients are taking warfarin and they're using THC at the same time, we're going to have to be adjusting those levels. And so this is also available on the MAR as a quick link, so providers and nurses can see, hey, my patient's also on this. Maybe we need to reconfigure some doses. So how do we know when a patient's taking cannabis? Before this project, it was really kept under the table. It was almost like a don't ask, don't tell. And you can guess what kind of issues that generated. So to combat that, what we did was we created an EPIC order and a medical cannabis administration MAR order. And this was a smart order, so it only allows the provider to successfully place the order if all the requirements were met, including like the no smokable cannabis, signing the acknowledgement form, etc. It also just takes that giant algorithm that we have and it places that into the ordering process. You can see that we also created links to those tip sheets that you saw, our policy as well. And then we have some administration instructions. It's not required for nursing to document how much a patient's self-administering, but if they want to put that in there, they're certainly welcome to do that, and they can just do that into the comment section. So let me go back here. This is a snapshot of the SBAR that was disseminated to nursing and providers. And it takes all that information that we discussed and crammed it into one page. And some of our higher usage units, such as like oncology and BMT, it's even posted onto the unit for quick reference. And this also has links to everything that was discussed today. And so what I want to talk about now is the hospital impact. We've had this policy live for over a year now, and the results that we've seen have been really quite immediate. Patients are able to continue their home regimen while in the inpatient setting. Most of the time we see patients using it for relief of nausea, pain, insomnia, and anxiety. In those patients that we've seen use it, there's a decreased reliance on opioids, which is a win right there. Interdisciplinary teams also know when a patient's using cannabis. As I mentioned before we started this work, it wasn't really known. And so you can imagine if you're like a hospitalist or a provider and you're taking care of dozens of patients and you might order something that's contraindicated with cannabis, now that doesn't happen anymore. Everything that's ordered is automatically verified with cannabis. So that's the good news for that. And then finally, it's safely stored. We've had no adverse events with any patients using cannabis. It's been really quite a miraculous process that's been developed. And then honestly, this is the most important effect of the work, and this is what it's doing for our patients. We decided to do some informational QI interviewing with our patients and why they've been using medical cannabis. And so what you see here on the screen are some of the reasons why they stated they were using it. And the quotes really pretty much speak for themselves. I mentioned before that I wasn't going to be glorifying cannabis and that it's not a benign drug, but honestly, for these patients, sometimes it is. I recently just interviewed a patient a couple months ago who was on the list for a heart transplant, and she and her father actually drove up from Southern California just to Stanford to get their transplant here, only because we allowed medical cannabis and we were the only hospital in California to do so. So when we first started this work, it was really to standardize our practice with patients and cannabis use and to make it safer for them in the hospital. But really little did we know the patient impact that we had. Almost every patient that we've interviewed consistently and independently remarks on how their dependence on opioid has decreased. And that alone, like I said before, is a win. A little bit more on patient outcomes. The table off to the left highlights just some demographics about patients. And we see patients coming from all sorts of backgrounds, genders, and clinical conditions. Historically, we see cannabis use higher in our oncology populations, which is still very strong, but other clinical conditions are starting to also take root here. The main reasons that people are using cannabis is for pain control. Almost 60% said that. Also insomnia, for nausea, and then anxiety. And then the table off to the right are the questions related to the informational interviewing that was completed. I'm pretty happy to report that a majority of the patients did not experience any side effects other than sleepiness, which was usually desired. A majority of patients were educated on the side effects that we created. There's still some work to be done there. And then a high amount of patients stated that the cannabis administration process was pretty effective and worked well. There are a couple of patients who did mark down only 1 star for the whole process, and that was only because they had to wait for a box. We initially procured 10 boxes for this. We weren't sure what the level of demand was going to be, and we have actually had to purchase more because we're seeing more patients request to use it. So back to where it all began. When I started this presentation, I was talking about this patient. As a reminder, he was suffering from bladder cancer that had metastasized everywhere, and he had just had a prognosis of weeks to live. And he was being administered end-of-life drugs by hospice and his family, mainly me. I'm his son, and we saw very little improvement. And so what we decided to do was try medical cannabis. And I'm going to say that most often cannabis is seen as a last resort for these patients. They're really desperate to try anything when other things just don't work. And with it, like many other patients, his opioid use decreased. We were completely able to get him off opioids. He was able to maintain sleep-wake cycles. He only lived for a few days after this picture was taken, but he did get his dying wish to hold his grandson one more time. And so the lesson here is that maybe it doesn't have to be a last resort. Maybe it can be used earlier in conjunction with patients and not just terminally ill patients. And maybe we'll start to see it incorporated more into the plan of care more regularly. With that being said, that's the end of my presentation. And if you have any questions about any of the content, I'm happy to take them right now, or you can always reach out to me.
If you have any questions, please enter them in the chat, and then we can facilitate. And as you see, we are having an issue with our CME code, so bear with us as we try to get that fixed. And if there's any changes after, we'll let you all know for the code.
I have a question. So Stanford's the first to have this policy. Have other healthcare systems reached out to learn about this policy, and have they reveal any of their barriers to doing that?
Yeah, we've had, I gave this presentation earlier this year at a conference, and I've been asked multiple times to help out with other policies across the states, especially as other states are kind of catching up to us. We're pretty novel here in California. And so other states don't really have the quite laws that we do, especially with the Senate laws, but there are other hospitals in California that have reached out with policy development. And this is actually also spread over to Tri-Valley as well.
That's great. And thank you for sharing your story.
Sure. Thank you. Let's see a question.
Other questions?
Oh, yeah.
Yeah.
It says, do you experience patients asking for medical cannabis as part of their pain management? Yes, we do. We have a lot of patients coming in, more than ever, who are asking for it. We actually just had a patient who had a pancreatectomy and wanted to use cannabis, and the providers were a little hesitant to do so, and so they had put the patient on opioids and lots of psych meds for anxiety, and after a week of that, just wasn't working, and so they'd finally allowed the patient to use it and was able to get off everything else. And so it's always nice to see that because it shows that it is working. I would love to see it incorporated more with maybe our palliative care or our pain management service lines, because I do think that it could really revolutionize the way we treat pain here. On that note, there are some clinical studies that are going to be starting here in the next year with patients in our urology department who are going to be using medical cannabis as part of their regimen, since other methods just haven't proved useful for them. So that's something that's going to be coming up too.
Thank you, Chris. Anyone else? Oh, it says, are traditional biases a factor on expanding the use as a pain reducer?
Yeah, I mean, there's still a lot of bias when it comes to that. You know, it wasn't too long ago that there was a lot of you know, reefer madness and propaganda about using cannabis. And so sometimes when we reach out to providers about using cannabis, it's really kind of shunned upon. There's really a lack of understanding. It's not really taught in medical school all that much. And so much of the job that we have to do is trying to educate providers on that and show them that, hey, this really is useful and it really is helpful for our patients. So I'm hoping that as we get more patients and more success stories, that word will spread. I mean, I'm really excited that we haven't had any adverse effects with this, with the dozens and dozens of patients that we've had. You know, no overdoses, no safe events. It's been pretty remarkable.
Thank you. Oh, another question. What are your thoughts on the potential effects of looming state restrictions?
Well, the state restrictions are always ever evolving. So as I mentioned earlier, the FDA and HHS is talking about decriminalizing it, or not decriminalizing, but descheduling it to a Schedule 3 status. And so that would really open up the whole marketplace for research on it, which I think is going to help out a lot to prove what it can and cannot do. The state restrictions, I don't think there's going to be any big state restrictions in California, since we are pretty novel here and we're pretty progressive, but you know, across the country, it's kind of hard to say.
Chris, it's Lisa again. I just think this is sort of a miracle that you got this instituted in the first place. Can you kind of talk more about like what that process was like, and you know, who was your coalition of the willing that kind of helped you get it started in the first place? Because I think a lot of people, they have innovations they want to introduce, and it just seems like the burdens to getting that done are so overwhelming. I'm still just gobsmacked at how you got this started in the first place.
Yeah, it was tough. I mean, I have to give credit. I did partner up with a lot of our palliative care providers who helped me out with this, who had a lot of experience in using it as a therapy. I also, one of my partners in crime was one of our risk managers here at Stanford. And so he was able to really look at the legality of it and kind of navigate those waters and avoid those icebergs of legal doom. And so that was a huge thing, was really trying to navigate it. Once we figured out how to do that, the rest was just getting everything in place. So, you know, getting pharmacy on board, and we created a task force. We met every other week for about a year and developing the algorithm and getting the lock boxes and getting pharmacy on board and double checking and triple checking. And then we finally had to send it off to California Department of Public Health. And we were expecting a really big pushback from them, but they were actually really easy to work with. They were pretty amazed that we were able to come up with a good plan of it. So it took a lot of work, and this was not just my work. This was the work of dozens of people. So credit to everybody. We're actually looking at publishing this here by the end of the year, and so we're going to be acknowledging everybody that helped out with that.
Thank you. Any other questions before we end? Thank you, Chris, so much. It was a pleasure having you speak for us.
No, thanks for having me. Yeah, and please reach out if you have any questions about cannabis in general or just how to use it in the hospital. I'd be happy to share what I have.
So much. Thanks, everybody.
Thank you.